facing Parker. Ideally, you would actually lower this table because you're going to have your patient grab behind their knee, and then you're going to help them lower back onto the table. So you want the table more around like mid-thigh of your patient, mid-thigh height. So this is a little bit too high, probably like mid-thigh knee. We're going to make it work though. The Thomas test MLT for TFL, all your hip flexors, so your 1 and 2 joint hip flexors. And when we get through the test, as we go through the test, we'll talk about how we're going to differentiate between the 1 and 2 joint hip flexors, and also which 2 joint hip flexors specifically you're going to be looking at. We'll probably spend a little bit of time on this one because there are so many different parts. It's a little bit like your pec minor MLT where there's different steps that you take. So stop me if you have questions. But first thing you're going to do, like I said, table lower would be much better. I know we can't do that today, but hopefully in the future, and obviously during the practical, we'll have high-low tables that you can do that. What you're actually going to have your patient do.
So you just have them sit on the very, very edge of the table.
So you're actually supposed to have them start in a standing position, and then they're going to try and grab behind their leg as you lower them down. Because the tables will have them start seated, I'm going to have you grab behind your right knee. And where he is good. You're aiming for about half the thigh to be off the table because you need it to be able to lower down and touch the table. You're going to support your patient. You can help guide them as they lay back. Good. Any pain there? A pillow under the head is good. You don't want a pillow under anywhere else because you don't want to affect lumbar flexion extension. What you're going to do next, you're going to reach behind your patient. So I'm going to roll him over just a little bit so I can get my hands under his back. You want to be palpating those L4, 5 spinous processes. And like how we practiced last week, you're just going to start flexing the hip a little bit, flexing and extending until you feel that L5 move. L4 shouldn't move, so that you're in that neutral pelvis position. Also helps make that testing position as objective and replicable as possible. Is that word, replicable?
Sounds pretty good.
Sounds super official, right? So I feel his L5 moving under my finger at this point. So I'm going to have my patient keep his knee there. So that's called setting the pelvis. Are we good on that? So that's patient positioning. He has enough of his thigh off the table. Hopefully you can see that. That I know the table isn't what's blocking his knee from coming down on touching the table. So the next thing I'm going to look at is his thigh touching the table? And his is. So we're actually off to a good start. He said he's tight. He's not looking awful. So
That's a good sign.
we'll go over what kinds of compensations and things you could see. So first thing is the thigh touching the table. His is. What sometimes you'll see is when they come back, I'm going to over exaggerate, is that the thigh will be up off the table and you'll see a huge gap. So this would tell us that the hip flexors are tight, but which ones would it be?
1 joint.
How do you know that? Because right now, 1 joint and 2 joint are both stretched, so we don't know. So that's the first thing you're going to look for, and that's how you're going to have to move on to your next step to see if it's a 1 versus 2 joint hip flexor. So what we want to do is, if his leg is out super far, abducted, you actually kind of want to bring it over a little bit. Note if there's any knee change, knee flexion change, and you can measure 2 things at this point. You can measure the degree that his hip is off the table, and you can also measure the knee angle. So the next thing we're going to do, we have it going? Sorry. So I'm just, let's say, sorry, can you hold your leg here? Let's say his leg is here. It's going to be the same where I'm going to be palpating that greater trochanter. It's going to be along the lateral femur and then parallel to the table. And let's say he's starting at 22 degrees of thigh off the table, or hip flexion, I guess you would call it. Okay, relax. So then if his knee was off the table or thigh was off the table, the next thing you'd want to do is straighten the leg. Why would I want to straighten the leg? It takes off your 2 joint hip flexor. So if he stays up and there's no change, then I know it's what?
One joint hip flexor.
So your iliopsoas. Or if it's up and it comes down a little bit, I'd still want to remeasure because then it would suggest that there's probably tightness in both, which is very common, especially since we all sit a lot more in our lives. You probably are going to have tightness in both your 1 and 2 joint. But so you're going to watch as you bring that knee up, if he's here, as you extend that leg, does it stay exactly where it is? Does it drop down? Does that make sense? So let's say he started here. I don't know if it's 1 or 2 joint. I'm going to extend. If it doesn't change, that tells me it's 1 joint. If it changes, if it's still up, it's both. But if it comes all the way down, we know it's not what?
1 joint. It's only 2 joint.
It's only the 2 joint. So if he comes from here and he comes all the way down to his thigh flush on the table, because we've taken off the 2 joint, we know it's not iliopsoas 1 joint hip flexor. I know
Does it tell you which 2 joint?
We'll get to that.
Oh.
Is everyone following that so far? Okay. So then the next thing that we're going to look at is in this position. So he has thigh flush against the table. We're also going to look at knee flexion angle. So normal is 80. Did we decide on 80? Okay. There's some debate between 80 and 90. So the normal knee flexion angle would be 80 degrees of knee flexion. So if he has thigh flush against the table, are you doing okay with your back, by the way? Normally do not keep your patient in this position very long. We're just trying to go through. So measuring the knee flexion, finding that lateral femoral epicondyle, up the lateral femur, down along the fibula.
Normal is 80 for knee flexion?
80 degrees of knee flexion.
In this test.
In this test. Not normal knee range of motion, this test. So he has 64, so I know that there's some tightness in the 2 joint hip flexor. And then to tell if it's rectus versus sartorius versus...
So it's more going to tell you, so if you slide out of the way so that they can see.
Sorry.
Rec fem doesn't have a rotation component, so you're not really going to be, usually that one is tight, we just kind of assume that. But if you're in an internally rotated position like he is, what would you expect to be tighter? TFL?
TFL.
And then if he's externally,
Sartorius.
and yeah. So he's in this internally rotated position. If I try to push him into external rotation, I'm getting a lot of resistance. So that would be, since I can't push him into external rotation, TFL. If he was externally, I can't even get there. If he was externally rotated, and I can't push him into internal rotation, and if he's kind of neutral, internal, external, I can push him both directions. That would be rec fem. Okay, relax.
Or equal tightness in...
Well, if there's no resistance, but yeah.
If there's no resistance.
If there's no resistance, then you would say rec fem. Questions on that? And then also, if I push him into internal or external rotation, if you see a change in the knee angle, you can remeasure that change. But just measuring that knee flexion, 80 is normal, and you can say he's at 60 degrees, so he's showing that many degrees of tightness. In case it's 62, I can't remember.
Do you ever measure at the hip?
When did we measure the hip?
In the beginning.
If it was what?
Right. But was there a normative? There wasn't a normative for that.
Flush with the
Or just
table.
flush, okay, right.
Flush with the table is normal.
We all measure sartorius and TFL, right? With the going.
If you see a change in the knee angle as you're bringing him into internal versus external rotation, if he comes way far out, if you're pushing him into more one or the other, or if he starts bringing that knee back in, then
you could measure the rotation of the hip in this position, in their resting position. So where he was sitting, he was probably in like maybe 5 degrees of internal rotation.
So you would come here and measure that same way that we just showed you. Does that make sense?
Yep.
Okay.
So theoretically, you could end up taking a lot of measurements in this position. Generally, I would say always, if their hip is off the table, always straighten the knee first and see where they're able to get to there. If the thigh is still off the table, that's where I would try and measure the hip flexion, and then allowing their knee to bend as far as it will without elevating the hip from that position, if that makes sense. It'll make more sense when you go through and practice.
So here, can you lay back real quick? What Dr. Parker is saying, I'm not going to reset, but so say he's here, and then you can bring the leg out and let the knee, or excuse me, let the thigh come down, so the thigh's flush with the table. He's saying then let go of the knee, because the knee will only go as far as the 2-joint hip flexor is going to allow it. Right. Does that make sense? That's what you're saying, right? Okay. All right. Oh, sorry.
Can you just go through the sequence again?
Yeah. Okay. So I'm going to have you seated. Again, because we don't have high-lows, and this may actually be your situation in the clinic where you don't have access to a high-low table. So starting in this position is totally acceptable too. Just making sure that where your patient is, he's not going to get his knee hitting the edge of the table, because that's going to limit your test. So I'm going to have you grab behind your right leg. You're going to help guide your patient down. Any pain there? I'm going to push him over so I can get my hand under his low back, and what I'm doing, I don't know if you guys can see this at all on the camera, I'm kind of using my thenar eminence to palpate that iliac crest, because what is at the iliac crest?
L4.
L4. So it's not 100% exact, but if I can palpate that iliac crest as I'm moving my fingers over to the spinous processes, I know that I'm going to be at L4, L5. And depending on what fingers you're most comfortable with palpating, I'm then going to use my fingers to palpate those L4, L5 spinous processes. Does that make sense? So then I'm going to roll him back so he's neutral, and then that's when I'm going to start flexing and extending the hip. And you can rock him. You can bring him out more if you're having a hard time kind of feeling when that motion started. Does that make sense? So here's where I start to feel the L5 move. So I'm going to say, patient, can you please hold your leg there and let it stay there, keep it there for the remainder of the test. We're good on patient positioning. Then I'm going to come around, and I would look from the front, I would look from the side. So I'd come here and I'd look to, I just don't want to block all of your views, but this is where I'd first come, and I'd want to see, is the thigh flush on the table? In his case it is. But in some cases you'll see, and you will see, there are super tight people where their leg will be up like this. That's when Dr. Parker was saying, straighten the leg. Is there any change? No change. I would measure this, and this is where you can have the patient help with one hand hold, or just knowing parallel to the table, find that greater trochanter, lateral femur. And then if there is change, where his thigh comes down, that's when you gently want to lower the knee. You don't want to just drop it, because that can hurt the knee. Comes down, I'm gonna just let his leg rest as it is. Again, this is when you want to come to the front, observe what you're seeing. So I can see that his hip is slightly abducted, and then he's slightly internally rotated, because that foot is out to the side a little bit. And then that's what we were saying about taking that knee measurement, lateral femoral epicondyle, up along the lateral femur, down along the fibula, taking that measurement. And then the other one that we were talking about is the internal rotation that we're seeing. So same measurements that we were using in the seated position. He's obviously supine-ish. But so middle of the patella, perpendicular to the floor, or again, ceiling, whichever you're comfortable, tibial crest. Good. And then I'm gonna push him into external rotation. I'm getting a lot of resistance. I can't get him into that external rotation. And if I push him into internal rotation, there's a lot more movement. So I know that because I can put him into internal rotation and I cannot get him into external rotation, what is probably most tight? TFL IT band. And we'll do another TFL IT band test next, but just thinking about that. Now, if he was sitting in external rotation, and I took that measurement, and I could push him into a lot of external rotation, but I could not get him into internal, what would I think? Sartorius. And if he was sitting neutral, not internally or externally rotated, and I had free movement both directions, rec them. Okay, thank you.